people and this thing.
77, that election Indira Gandhi lost, no?
Yeah. And Sanjay Gandhi was this thing, used to collect money. If people don't give money for that brigade, they were not seen at all for a few days till they. And Miranda College, so many girls are missing. One of my uncle's relative, engaged. Yeah, sorry then.
Chalo, let's start.
Hello.
Can we start, Satish?
Yes, sir. Yes, sir. You can start.
1 minute,
Sir,
1 minute there. 1 minute there.
Yeah. So, students, you can actually introduce yourself with your designation and the institute. And you can start.
And put on your video.
Video is on.
Dr. Hemant and Jagdish, put on your
Hi.
videos.
Yes, sir.
Good evening, sir.
Good evening, sir. Myself, Dr. Hemant, and my friend Jagdish. Today, we are discussing about some dog bites, snake bites, scorpion sting, and human bites, some other things. Initially, dog bites, sir. Dog bite may cause rabies, which is caused by Lisa virus that causes fatal encephalomyelitis. Pathogenesis, sir. Am I audible, sir?
Yeah.
Yes, you are.
Rabies virus is neurotropic, sir. It enters the peripheral nerves or cranial nerves from the damaged nerve endings and from the site of the bite, ascending up through the dorsal root ganglion, spinal cord, and finally reaches the brain where it multiply enormously. From there, the rabies virus subsequently descend down to all secretory glands, salivary glands, mammary glands, sweat glands, and urine via sympathetic nervous system. Average incubation period is 30 days to 90 days, sir, but it may vary from months to years.
The longest incubation period reported is said to be 11 years.
Yes.
Yeah, it's about it long, Yeah. Not, I didn't know exactly 11 years. It is further, I said years. Yeah. So.
We can see some case scenario, sir. Case scenario 1: a 3-year-old male child had dog bite on right thigh with a wound size of 2 centimeters and 2.5 centimeter while playing with unvaccinated dogs. We can discuss answer now itself, sir, or later we can discuss, sir.
Whatever way you want, you are the boss.
You are the teacher and we are the listeners.
Sir, here it is a category 3 dog bite, sir. Management will be first we have to wash the wound thoroughly under running tap water, at least 15 minutes with soap. And the next thing is we have to give active immunization with rabies vaccine, sir. Dose may be essence regimen we have to follow 037, 14 and 28, or short essence regimen 037 and in between 14 and 28 days. And this is category 3. We have to give rabies immunoglobulins also, sir. Either equine or human immunoglobulins or monoclonal antibodies are also available, sir. And case 2 scenario, sir. A 12-year-old girl had.
No, just 1 minute. Did dog bite was treated during your time in railway hospital?
Yes, sir.
Or yeah,
yes, sir.
you could have presented as a case report and then discussed. Okay.
Second case scenario, sir. A 12-year-old girl had dog bite while walking on the road on the right leg. On examination, minimal bleeding was seen at the bite mark, sir. Child had vaccinated 4 months before for the category 3 dog bite, sir. In this scenario, we have to treat first initially with wound care, sir, under running tap water, then followed by since it is more than 3 months, so we have to give again anti-rabies vaccine, sir. And rabies immunoglobulins not needed, sir, in this case. We have to give, sir. Sorry, sir.
Go ahead. If it is less than 3 months, what do you do?
Less than 3 months, sir. Wound care is sufficient, sir.
Okay. Okay.
Sir, scenario 3, sir. A 6 years old child had dog bite on the right forearm, reported to the hospital after 1 month of the dog bite, sir. On examination, healed scar and white mark is visible, sir. This is also comes under category 3, sir. Wound is already almost healed, sir. We have to give rabies vaccine and rabies immunoglobulins also we have to give, sir.
What you said 1 month.
Yes,
What is
sir.
the usefulness of immunoglobulin after 1 month?
Sir, that vaccine also not given for this child, sir. So we have to treat it as a new case and we have to give vaccine at the same time immunoglobulins also, sir.
What is the longest? Suppose a child had come to you after 3 months. Will you still give immunoglobulin?
Previously not vaccinated, it is category 3. After 3 months, we have to give vaccine same and at the same time immunoglobulins also we have to use.
So what is the window period beyond which you don't give immunoglobulin?
3 months, sir.
3 months. What is the reference? What is the reference? Actually, there is no mention about it in literature. That's what is a gray area. It's a gray area. But generally, if it goes beyond 1 week, the effectiveness of immunoglobulin is questionable. Questionable because you expect the virus to settle down in the nerves and ascend up. And immunoglobulin will not have any effect on any virus which is attached to the nerve or to the cell per se. Right? Beyond 1 week, it's of questionable efficacy, but unfortunately, there is no data that you should not give beyond a particular period. Right?
Yes,
Yeah.
sir.
Yeah, because immunoglobulin itself have been created some problems in some people.
Yes.
Yes.
These are the categories of dog bites, sir. Category 1, touching or feeding of animals, lick on the intact skin. Category 2, nibbling of uncovered skin, minor scratches or aberrations without bleeding. Category 3, single or multiple transdermal bites or scratches, licks on the broken skin. Contamination of the mucous membrane with saliva, sir. Here, category 1, no need of any treatment, sir. Category 2, we have to give wound management and after that, we have to give anti-rabies vaccine, sir. In case of category 2, the child is immunocompromised, we have to give immunoglobulins, sir. And in category 3, we have to give wound management, rabies immunoglobulins, and rabies vaccine also, sir. Same. Approach to post-exposure prophylaxis, sir.
What do you do? What do you do if a person is bitten by a cat or
About to ask, yeah,
cat
cat
or a rat? What are you going to do? Or mongoose?
and squirrel and this thing bats. Actually, one of our JIPMER graduate student, he died in USA. So he was this thing, So bat is also one of the important thing. Nowadays, they have found the squirrels are very common in USA. So squirrel also can transmit rabies. That's what recently I read. Yes, you can check that.
Sir, cats, we have to give anti-rabies vaccine, sir, in category 3.
What about rats?
Rats, some domestic rats, no need, sir. It's a zoonotic or wild, we have to give, sir.
Yeah, any domestic animal, there is no need. Any other than dog, any cat you should give. And in India, the recommendation for bats is very clear. In India, there is no bat transmission of rabies virus.
Yes, sir.
There is no transmission of rabies through. Hello, please mute yourself. Yeah. There is no transmission of rabies by bats in India so far, and it is not recommended.
Yes.
Basically, anything domestic, you don't give prophylaxis. Anything wild, you always give prophylaxis. What about monkeys?
Monkeys also, we have to give vaccine, sir.
You have to give. In fact, the highest number of cases of monkeys transmitting rabies occurs in Nepal.
Yes.
Nepal. In fact, Australian government recommends that tourists who go to Nepal should take rabies vaccine. Monkey bites are so common, I believe, close to the temple, Pashupatinath temple in Nepal.
Yes.
So
Nowadays
monkeys.
in Agra also it happens. All these monkeys, they start coming and pestering and then biting. So Thailand also, they have monkey park. There also this is very common. So it's very important that they have to,
Go
because
ahead.
any animal can transmit.
Okay.
Yeah.
Squirrels, I'm surprised. This is the recent thing I read about it. Yeah.
Approach to post-exposure prophylaxis, sir. Management, initial management will be the local wound washing under the running tap water, sir, at least for 15 minutes with soap. And next, active immunization with anti-rabies vaccine, sir. In case of suturing cannot be avoided, clean the wound thoroughly. After that, we have to infiltrate equine rabies immunoglobulins or human rabies immunoglobulins, sir. Then suturing should be delayed, sir. Why? Because we have that infiltrated immunoglobulin should enter the wound thoroughly, sir. For that, we have to delay some suturing, sir, sometime.
Okay.
Then passive immunization we have to give with rabies immunoglobulins or rabies monoclonal antibodies. And human rabies immunoglobulins dose available is 20 international unit. Dose we have to give is 20 international units per kg body weight, sir. Maximum dose is 1500 international units, sir. Source it is prepared from human serum, sir. Equine rabies immunoglobulins we have to dose recommended is 40 international units per kg body weight, sir. Maximum dose 3000 international units, sir. Source it is prepared from horse serum, sir. Monoclonal antibodies dose is 3.33 international units per kg. Strength available is 100 international units per 2.5 ml or sorry, sir, 100 international units per ml or 250 international units per 2.5 ml per vials available, sir. Twin Rab, sir, it is a murine monoclonal antibodies. It is a combination of docaravimab and miromavimab, sir. This is dose is 40 international units per kg body weight, sir. Strength available is 600 international units per ml or 1500 international units per 2.5 ml, sir. They bind to they bind to two different epitopes of the G protein expressed on the surface of rabies virus, sir. They neutralize both rabies and rabies-like viruses, sir.
Is it available easily or what is the cost?
Actually, WHO recommended, sir. Cost exactly not sure, sir.
Yeah, and also the type of wound, the category of wound. It's not necessary that every child should be given, need to be given immunoglobulin. It depends upon the category of this thing which you already mentioned.
Yes, sir.
Okay.
And it should be given along with the vaccines.
Yeah. In railway hospitals, have you treated any of these cases with immunoglobulin?
Yes, sir. We have given many cases, sir. We are
of course, because railway, it's a free, it's given free to the employees.
Yes, we are having equine rabies immunoglobulins and rabies monoclonal antibodies.
Yeah, that is freely given to employees of railways, no?
Yes, sir.
Yeah.
Active immunization, sir. Post-exposure vaccination schedule, sir. We are here Essence intramuscular regimen and updated Thai Red Cross schedule will be available, sir. Essence intramuscular regimen contains 5 doses, sir. 0, 3, 7 and in between 14 and 28, sir. Shortened Essence regimen contains 4 doses, sir. 0, 3, 7 and in between 14 and 28 days, sir. Updated Thai Red Cross schedule contains 2-site regimen, sir. Dose is 0.1 ml, sir. We have to give 2 sites on 0, 3, 7 and 28 days, sir.
Yeah. So the advantage is lesser
Lesser
is used. Yeah.
Cost effective, sir.
Yes.
And then pre-exposure prophylaxis, sir. According to WHO and IFP, there is a 2 schedules, sir. 2-site intradermal on day 0 and 7, sir, or else 1-site intramuscular on day 0 and day 7, sir. As per NCDC, there is a schedule is IM on days 0, 7 and in between 21 and 28 days, sir. Intradermal, here we are giving only 1 site, sir, on the day 0, 7, 21 and in between 21 and 28 days, sir. 3 doses we are giving, sir. With in case of re-exposure, sir, if it occurs 3 months or more, after completed documented vaccination, we are giving 2 doses, sir, 0 and 3 only.
Actually,
Yeah.
WHO says 3, 0, 3, 7, and 14 is enough.
Yeah.
Only the Indian guidelines continue to say you better give 5 doses, 0, 3, 7, 14,
30.
and 28.
Okay, sir.
Right?
Yes.
That too, if you give immunoglobulin or monoclonal antibody, 4 doses are good enough. In fact, all of us should remember, originally when we started the anti-rabies vaccine, we used to give 6 doses,
Sir.
0, 3, 7, 14, 30, and 90 also.
Yeah.
90 was
Nine.
withdrawn because of allergic reactions and adverse effects. Okay.
Sir.
Now, even the 28, they say may not be required if you have given immunoglobulin or monoclonal antibody.
Okay, sir.
Right?
Okay, sir.
And the other development which has now taken place is that
Sir.
equine rabies immunoglobulin is more difficult to get
Sir.
than monoclonal antibody. Monoclonal antibody is more easily available. 2 brands are there. Both have been proven to be as effective as rabies immunoglobulin. Hello, hello.
Somebody is talking.
So, rabies monoclonal antibody, both the brands have been studied well and they have reported the equal efficacy compared to the immunoglobulin. So, in most centers, they have stopped using immunoglobulin.
Okay.
And giving equine immunoglobulin is a risky affair with the risk of anaphylaxis. You have to give a higher dose. The other development which has taken place, which has changed over the last decade, is that previously we used to give as much possible locally and give the remaining intramuscularly. That recommendation is gone. Everything should be given only
Near the site of the.
near the site, infiltrate rather than as immunoglobulin.
Yes. Okay.
Okay, please go ahead. Now, 1 minute, just two or three things. Suppose you find, I'll ask you 1 or 2 questions before we move to the next.
Okay.
Suppose you find that somebody comes to you
Sir.
saying that the dog is fully vaccinated.
Sir.
Okay. And it is a category 3 bite or 3-2 bite or 1 bite.
Sir.
Will you say, no, we can wait for 10 days?
No, sir. We have to give 0, 3, and 7 dose, sir, and we have to wait for the 10 days whether dog is alive or not. If dog is alive, after that, no further vaccination is not needed.
Actually, that recommendation is not correct.
Sir.
You should continue the vaccination whether the dog is alive or not, because rabies carrier state has well been documented in dogs.
Very well documented. So it's
Very
no
well
longer
documented. In
yeah.
fact, you can actually, there is one Professor Balaraman, former professor of Madras Medical College.
Sir.
He had actually reported carrier state in dogs. Even veterinarians have reported. And Dr. Balaraman has also documented cases of rabies in completely immunized, even due to bites from so-called completely immunized dogs. You don't know how the cold chain had been maintained for the dog vaccine. You don't know the quality of the vaccine. All those things are there. It is better not to take the 10-day window period as a safe sign.
Okay, sir.
Better to complete the vaccination.
Okay, sir.
There are enough number of cases which have been reported following carrier dogs transmitting rabies, however rare it is.
Okay, sir.
Okay. Okay. One more question. Suppose you are seeing a child who has received rabies vaccine,
Sir.
and the mother says the nurse gave it in the buttock. What do you do? Buttock.
Sir, we'll check for any local reactions, swelling.
Pardon?
We'll check for any local reactions, or swelling.
Any other answer from any other PG?
For immunogenicity in buttock.
No, any rabies vaccine which is given in the buttocks should be discounted, ineffective. Ineffective. Like hepatitis B vaccine, rabies vaccine should never be given in the buttocks. It has to be given only intramuscularly, preferably in the shoulder or in the anterolateral. If it had been given in the buttock, that dose should be omitted. You should repeat the dose.
On the same day we can give, sir, or else next
Same day you can give. Same day you should give. Not
Okay.
you can, you should give.
Okay.
Okay. The other comment is intradermal has been found to be as good as intramuscular. Only thing is, it is recommended only in a public health setting, not in a practice setting.
Okay.
It's not recommended for, a clinic. It's recommended only in a public health setting.
What is the reason? Why?
Reason because, see, you need trained personnel to give intradermal.
Intradermal. Okay.
That might be the reason, but it is recommended. It's better not given in a private setup. And the reason why it is given in the public health setting is to save money.
Sir, I am muting myself because outside the grass cutting is going on, so it's making a lot of noise.
No problem, no problem. No
Okay, I'll just.
Okay. Yeah, if there are no other questions, sir, Professor Bagdi had some comments.
Yes, I have one doubt, sir.
Yeah.
No, medico legally, if your neighbor's dog bites you, who
Yeah.
pays for the vaccine? Yourself or the neighbor?
I think that that's a social question. It's not a medical question. Good
No,
question.
I'm just asking you.
Yeah, why you are worried?
As long as the neighbor is not somebody who bites you, they'll pay for it.
Yeah, they may
What is
come
the
and shoot
cost
you
of the
if you
monoclonal antibodies, sir? So,
It's not as costly as immunoglobulin. It's much cheaper. It's only about few thousands only, not in 10,000s. Okay.
Yeah. So we always convince the parents saying that you are spending so much of money for so many functions. Why not for saving your child? Because you cannot take risk.
Yeah.
So if
no,
you
I
tell
was
them
thinking if
they
an immunized dog bites, you don't have to give vaccine. I have learned something today, really.
Yeah. The other point postgraduates must remember, if it's a lacerated wound, if due to a dog bite, particularly close to the face and risky areas, you have to give antibiotic prophylaxis to cover anaerobic organism. The drug of choice is amoxiclav. Should be given for a period of minimum 3 to 5 days. Prophylaxis. For that matter, any animal bite which is deep, you are expected to give amoxiclav 3 to 5 days. You shouldn't give amoxicillin. You should give only amoxiclav to cover anaerobes also. Okay. Yeah. If there are no questions, we can move on to the next one.
In case of re-exposure, till how many years it will be 2 doses only? Suppose the dog bite is after 5 years. Still it will be 2 doses?
Same. Immunological memory, only 2 doses. Lifelong.
Thanks.
Lifelong. Yeah. T-cell memory will remain, and 2 doses are good enough to revive the memory. Okay.
Okay.
Please go ahead.
Scorpion sting envenomation, sir. In India, we are having most commonly 2 species: red scorpion and black scorpion. These are most commonly seen. These are poisonous. Red scorpion is more poisonous than black scorpion, sir.
Is it not called phlebotomous stimulus? Is it a Hottentotta?
Recent NTG, they changed the names.
Change the name, huh?
Yes,
Okay. Or phlebotomous or Hottentotta stimulus. Okay, fine.
Some case in sir. 4 years old male child brought with the history of the child was playing in the garden unattended and was found crying and holding his hand. He said something with him. On examination, he has swelling and severe inflammation on the dorsum of the right hand with ecchymosis in that area. He is sweating, tachycardic and disoriented. He has mild hypertension. He vomits during examination, sir. Discussion, sir. This is a small child, hence insect or a snake bite is possible. He has signs of local inflammation, hence local tissue reaction has occurred. He has features of an autonomic storm. no features of coagulation failures. Hence, scorpion bite may most likely diagnosis, sir.
What are the clinical features of autonomic storm?
Uh,
You have
palpation.
to mention that because,
sir.
yeah.
Uh,
It can have both
Yes, sir.
autonomic
Tachy-
storm and sympathetic as well as parasympathetic. So
Parasympathetic.
it is important what is predominant.
Yes, sir. Parasympathetic, there will be increased sweating will be there, sir. Vomiting, tachypneic, and priapism will be there, sir.
Priapism may be there. You may have tachycardia.
Hypertension.
You can have even hypertension in the early stage.
Yeah.
Hypertension may come late. Hypertension may be there initially, right?
Non-cardiogenic pulmonary edema may be there, sir, because of increased secretions.
Okay.
Then sympathetic, it will be hypotension will be there, sir. Bradycardia will be there. Mydriasis will be there, sir.
What is the mechanism by which autonomic storm is caused by the scorpion sting? Channel is a channel disturbance.
Channel
Channel disturbance. It's almost akin to channelopathy.
Yes.
Yeah.
Gate disturbance. Okay, right.
These are the
I'll
clinical.
tell you, sir, if you don't mind, I'll tell you this thing, Initially, when we were house surgeons, that is 1969-70, the village posting will be there. So a lot of cases. So Yamatine was injected in the area of bite. And then subsequently, Lighty cocktail was there. If you must be knowing about Balacobal juice recommendation, which contain pethidine, etc. And then pethidine can enhance the toxicity of scorpion inflammation. Then subsequent that was read, and then subsequently, of course, this development has come due to Bavaskar. Yeah.
Please go ahead.
Sir, symptoms may be first initial 30 minutes. There it may be asymptomatic or local symptoms may be present. Local symptoms, excurate pain will be there. We can confirm it with tap signs, sir. When we tap the bite site, there will be more pain. Excruciating pain will be there, sir. This is tap sign. Later up to.
No. Please elaborate. What is tap sign? How do you elicit?
Sir, if you tap on the bite site, it will be more excruciating pain, sir. Pain will be there, sir. That will be the tap sign, sir.
Go ahead.
Up to 6 to 8 hours, there will be autonomic storm, sir. Initially, parasympathetic excess phase will be there, sir. In that, projectile vomiting, sweating, increased sweating, salivation, meiosis, increased bronchial secretions will be there, sir. Bronchospasm will be there, priapism, bradycardia, and hypotension will be there, sir. And after 8 to 12 hours, after that, sympathetic excess phase will be there, sir. In that, hyperglycemia, mydriasis, tachycardia, hypertension, and cold extremities will be there, sir. It mimics circulatory failure. Sometimes these both features will overlap in between, sir. After 8 to 12 hours, there will be myocarditis and myocardial dysfunction will be there, sir. In early CCF, tachycardia, tachypnea, basal crepitations will be there, sir. And elevated JVP will be there with the normal blood pressure and no hypoxia, sir. In late CCF, there will be pulmonary edema, sir. Increased work of breathing will be there, sir. Hypoxia not responding to oxygen supply will be there, sir. And finally, cardiogenic shock will be there. After 24 to 36 hours, resolution phase will be there.
Go ahead.
Do's and don'ts in scorpion sting evaluation, sir. Do's report to hospital immediately. Observe for at least 24 hours minimum, sir. Position must be given at the first sign of autonomic storm as early as possible, sir. Don'ts do not use tourniquet. Incision and drainage is not recommended.
What is the dose you'll give?
Sir?
And what is the dose you'll give? How many micrograms per kg?
Positions are 30 micrograms per kg.
Yeah.
We have to give, sir, at every 4 to 6 hours. You have to.
Yeah, and of course it can cause postural hypertension, so one must be also not to this thing.
Yes.
Yeah, okay. Then of course if the child cannot swallow, then of course by tube you have to give gastric tube.
Okay. And prophylactic antibiotics not needed, sir. Steroids also not needed, and lytic cocktail is not recommended nowadays. Investigations are recommended are CBC, renal function test with electrolytes, sir. Chest X-ray we have to do, sir. And serial ECG monitoring we have to check, sir. There will be prolonged QRS complex and increased T waves, and there will be ST elevation or depression will be there. So we have to do serial ECG monitoring. We have to do. Management, sir, for local pain, oral paracetamol 15 mg per kg we have to use. Then antidote is prazosin, sir. It is a pharmacological and physiological antidote, sir. It is alpha 1 blocker, reduces the preload and left ventricular afterload, sir. Dose is 30 microgram per kg per dose, sir. Every 4 to 6 hours you have to use. Indications: autonomic storm, sir. Myocarditis without cardiogenic shock, sir. It is not a comment, sir. It is no role in giving prophylactically until the autonomic storm we have to suspect. It will cause hypotension, sir. Then we have to check for the BP after giving the first dose, sir. In case of cardiogenic shock, we have to give cautiously, sir. It is a photosensitive drug, so we have to keep away from the light, sir. Indian SCARP antivenom is available in some areas, sir. It is a monovalent, sir. It neutralizes the venom, sir. 1 ml neutralizes the 1 mg of red scorpion venom, sir. We have to give three vials of scorpion antivenom, 30 ml plus 70 ml of normal saline in 100 ml over 1 hour, sir, as a slow infusion, sir.
Sir, is it available in Jipmer, sir? Antivenom?
It's available, and this study has been done, comparative study with and without that, and of course it is useful. Okay, so I actually invited Mahadevan. If you are available, you can come, because you have done so much of studies on these two things, but unfortunately he is occupied. He is traveling somewhere.
Yeah, because he has published data on, I think in Archives of Disease, he has published the article on scorpions.
Yeah, and also the standard this thing, and he attended this thing committee meeting with Simpson for Indian Pediatrics Desk, So he is one of the attendees of this thing for recommending the guidelines.
Yeah. Two comments. One is that most children don't require more than 2 doses of prazosin. Beyond 4 hours, they go in for.
Usually it's so. Most of the cases don't need at all, because I have been watching this.
Second dose 3 to 4 hours maximum. Other further doses very rarely required. And studies, in fact, Bavaskar himself says that there is no need to use scorpion venom. He says prazosin is physiologically such a good antidote. Whatever the venom does at the channel, prazosin.
Yeah, we haven't had any mortality only with prazosin. Only after the venom this came, antiserum came, then people are this thing. He did a comparative trial with and without that. It was published also. Mahadevan. That's why I wanted him to be there.
Please go ahead.
Indication of scorpion antivenom, sir, may be given if patient present within 6 hours, sir. Within 6 hours of sting, sir, with autonomic storm, sir. No survival benefit over prazosin is seen, sir, except for early resolution of symptoms will be there, sir. But life-threatening anaphylaxis and deaths are reported after giving scorpion venom. In case of children with early CCF, sir, dobutamine infusion we have to use, sir. 4 to 6 microgram per kg per minute, sir. And titrate up to 10 to 15 microgram per kg per minute, sir. Target is to normalize the peripheral perfusion and decrease the heart rate, sir. Child with late CCF with pulmonary edema and cardiogenic, sir, we have to give non-invasive support, sir. If not improving, we have to intubate within. Not improving within 1 hour, sir, we have to intubate and give adequate positive pressure ventilation with mechanical ventilation. If pulmonary edema and hypoxia persist even after the positive pressure ventilation, sir, we have to start sodium nitro intravenous sodium nitroprusside, sir, at the dose of infusion 0.5 to 1 microgram per kg per minute, sir. Rarely, children may present with atypical features of central nervous systems like seizures and encephalopathy, sir. In that scenario, the treatment should be purely supportive, sir. Benzodiazepines are the first line agent for controlling seizures, sir, followed by phenobarbital and levetiracetam, sir. Phenytoin should be avoided, sir. It may increase the arrhythmias, so it should be avoided. Sir.
2 or 3 points. One is that prasosine should be given at the slightest symptom suggestive of the autonomic storm.
Okay,
So that is based on clinical assessment.
sir.
It's number one. Number two is that dobutamine is very specific. It is better to avoid dopamine because there is overpouring of catecholamines. There's no point in giving more of dopamine.
Okay.
Adrenaline also in a similar note is to be avoided.
Okay.
Third, lytic cocktail, which was used as a combination of Largactil and your morphine.
Petrin.
Yeah, Petrin is no more recommended. Wherever they have used corticosteroids or they have used lytic cocktail, studies have shown more mortality. If at all sedation is to be given, these children, the safe sedative has been benzodiazepine, and midazolam or diazepam rather than the other agents. And phenytoin should be avoided. If there are seizures, you can use levetiracetam, which is again a benzodiazepine modification. Too much of vasopressors will do harm and will cause cardiac toxicity rather than do good to the child. In general, the younger the child, the more is the severity of manifestations, and more is the mortality. In fact, thanks to Dr. Bavaskar, we have been able to save quite a few lives by using prasosine, a wonderful drug. And as rightly pointed out by Professor Srinivasan, Dr. Mahadevan has done pioneering studies in this area. It's very nice if you had been here today with us. Okay. Any other comments, sir? Professor Srinivasan, you would have seen lots and lots in JIPMER.
We have seen, of course, most of the studies, of course, he has been doing it, and he has published it also, and of course, guidelines also has been made. The standard treatment protocol, no? It was snake bite was by Singaravelu and people from Kerala, Mohan, Vijay Mohan. But standard protocol for scorpion bite sting is Dr. Mahadevan.
Yes, sir. Yes.
Yeah.
Yes. Yeah. Thank you. Well done, doctor. Yeah.
Sir, thank you.
Continue.
Jagadish.
Who next? Yeah, please introduce yourself. Make it full slide.
Sure.
Good evening, sir. This is Dr. Jagdish. This is Dr. Jagdish.
No, you are connected to more than one device. Switch off the other one. Yes, Dr. Jagdish, please go ahead.
Good evening, sir. This is Dr. from Southern Railway Hospital. Today I am going to discuss topic about snake bite, bee and wasp sting and human bites. First, I will start about discussion on snake bite. Introduction. India records the highest annual incidence of total and fatal snake bites in the world. The 70 out of 330 species of snakes in India are poisonous. In this, 70% are non-venomous and 50% of venomous are mostly dry bites. Snake bites mostly occur in the rural and agricultural areas in the season of April and October. The most common bites are hemotoxic and neurotoxic snake bites. Hemotoxic is caused by the saw-scaled viper and Russell viper, and neurotoxic bites by common kite and Indian cobra. Now we will discuss about the case scenarios. In a case scenario 1, a 12-year-old boy was brought to the casualty.
And one more is the sea snake with flat tail. That is the
Myotoxic.
myelitis will occur. Okay, so yeah, myotoxic.
In a case scenario 1, a 12-year-old boy was brought to the casualty with a history of snake bite over the right thumb. He had a severe pain over the bite site with progressive swelling. There is also a history of bleeding from the wound site and passing red color urine. As there is a conceptual coagulopathy and a history of bleeding, it mostly it favors the hemotoxic snake bite. In a case scenario 2, a 5-year-old girl was sleeping on the floor with her parents. At present, the casualty is unable to talk, breathing difficulty, pain upon vomiting. She also had a ptosis. It mainly favors around a neurotoxic bite, but we have to first check for the bite marks. In case of tight bite, there will be occult snake bite. There won't be any bite marks, but can present with the neurological features. So you have to manage accordingly.
Yeah, one more important is epidemiological feature. Where exactly happened? See, we had a case in Mahatma Gandhi Medical College. This thing, wedding hall. Children were sleeping on the floor. So child had this thing, paralysis and came to this our place, and then this particular history made us think of, because it presented as lock-in syndrome. Only eyeballs are this thing. Child is awake. Otherwise, all the limbs are this thing. So one must try to find out where exactly happened. That suspicion, index of suspicion is very important. Okay, yes.
We will see the images of the major snakes. This is a saw-scaled viper, first one. Second is a Russell viper. This is Indian cobra. You can see that fang mark, and then the straight bite. First, after the snake bite, the first aid should be given. First, that is do it right. Right is reassure the patient that mostly 70% are non-venomous snakes, and reduce the patient anxiety, and immobilize the bitten limb as in case of a fractured limb, and get to the hospital immediately by ambulance, and tell the doctor about any symptoms so that management can be started. And you should not block the blood supply, apply pressure over the bitten site, and you should not tight ligages and use bandage or cloth to hold the don'ts. We should not wash the wound, as washing the wound increases the venom in the circulation, and we should not apply tourniquet. It leads to necrosis of the bite, and the incision suction is avoided. And you should not apply electric shock or cryotherapy to the wound, and also avoid pressure over the bitten site.
You should not apply suction, or you should apply suction. You go to the previous slide.
Should not, sir. Don't.
Should not. Be careful. You should not. Okay.
Okay.
Thank you.
Symptoms. The local symptoms, there will be pain, discoloration, fatigue, swelling and bleeding and blistering, and necrosis and tingling and numbness can be present. And systemic features, there will be conceptual coagulopathy, acute renal injury, shock, myocardial damage, arrhythmia, neuromuscular paralysis, and rhabdomyolysis. And the locked-in syndrome, the patient can mimic the brain death and present to the casualty. This is the condition in which we can give CPR more than 20 minutes. Because it mimics it. We can differentiate from the brain death and the locked-in syndrome. Is only the eye movements will be vertical eye movements will be present.
Actually, this child was they wanted to give immunoglobulin, thinking it's Guillain-Barré syndrome, but finally, the circumstance only made us think of, and immediately anti-snake venom was given, and child started showing improvement. And later, and it's a girl, and it was the fang mark was there in the behind the this thing, pigtail. So when it was lifted, then the two marks were there, fang marks. So you must always look for fang marks, you know.
So to
Yeah.
expose fully and you have to.
Proceed.
No,
We can
previous
start.
slide. We have not completed the 5
Yes,
P
sir.
and 2 Ps.
The 5 Ps are ptosis and paralysis, and 5 Ds are diplopia, dysphagia, dysarthria, dysphonia, and dyspnea. So we have to look for 5 Ds and 2 Ps in the case of neurotoxic snake. The symptoms can be classified based on the species of snake bite. In cobra, mostly present as local pain and tissue damage and ptosis, and the cause of death is respiratory depression. In kite, there will be only present with ptosis and neurotoxicity, and there will be respiratory depression. In the Russell viper snake, there will be all the symptoms like local pain, tissue damage, ptosis, coagulation problem, and renal problems. So it is the most severe type of snake with Russell viper. It presents as a respiratory depression or circulatory collapse. In soft scale viper, there will be local pain and there will be coagulation of ptosis. The cause will be circulatory collapse or respiratory depression. In investigations, first investigation we do is a 20-minute cold bed.
Soft scale viper and Jipmer being this thing, you know, casual forest, it was a forest area. So there are a lot of this thing. So renal failure is a very common feature.
And it can usually renal failure occurs when inadequate doses of anti-snake venom is given.
Yeah.
Investigation. First, we will do the 20-minute cold bed clotting time. This 2 to 3 ml blood is collected in a glass container and is stored undisturbed for 20 minutes. And after 20 minutes, filtered for 45 degrees and checked. If there is no clot formation, there is hypofibrinism, then the snake envenomation has occurred. Hemostatic toxicity has been occurred.
The test tube should be free of detergents, very important, which can cause false results.
And look for the coagulation power like PT, CT, PT, APT, INR. Fibrin of the levels, D dimer levels can be seen. And the CBC to look for any hemolysis, hemoglobin. And peripheral smear to look for a hemolytic picture. And the urine examination for myoglobin or hemoglobin. And we look for the CKMB. It will be elevated due to myolysis. And renal function test to look for any acute kidney injury. And ECG can be done. It's not specific. Maybe the hyperkalemia, there will be tall T waves or a AV block will be there. The ST segment elevation can be. First, management. First, we have to classify this as life-threatening. First, we have to check for ABCD. We have to assess the airway breathing, circulation, disability, and exposure. If an airway, look for any secretion and palatal paralysis. If the airway is compromised, you have to go for mechanical ventilation and stabilize the patient. And breathing is to look for bradypnea, shallow breathing, and respiratory arrest. In the circulation, there will be autonomic disturbance, hypotension, or cardiac arrest. And the disability, there will be altered mental status, neuroparalysis. And the exposure, look for fang marks or a bleeding on the cellulitis. The specific management will be starting on anti-snake venom. The ASV is a polymicrobial. It acts against all 4 snake types. And indications are in any systemic symptoms like neurotoxicity and acute renal failure, bleeding or coagulopathy or myoglobinuria or hemoglobinuria and cardiac toxicity. The ASV should be started immediately. And local swelling involving more than half of the bitten limb, the rapid extension of swelling, and the development of enlarged tender lymph node draining the bitten limb. These are the indication for ASV. Skin testing is mostly not needed before starting ASV, as the endodermal allergic target IG mediated, whereas ASV reactions are complement mediated. So there is risk of pre-sensitizing the patient and making the reaction more likely, and there is a waste of time before starting AS. Dose. The dose of ASC can depend on the severity of the envenomation. In mild, the amount of antivenom needed is 5 vials. In moderate, 5 to 15 vials. In severe cases, that is 15 to 20 vials. But first initial dose, we start with 10 vials, dissolved in the solvent and diluted in 5 to 10 ml kg of normal saline or 5% dextrose, and administers IV infusion over 1 hour, slowly over IV infusion. In a hemotoxic envenomation, repeat dose can be given after 6 hours if the whole blood clotting times remains abnormal. The whole blood clotting time is repeated every 6 hourly. The time required by the liver to restore the clotting factors. The maximum 3 doses can be given. Maximum mileage 30 vials can be given in hemostatic. In neurotoxic, after the first dose, if paralysis persists, we can give second dose after 1 hour of the first dose. Maximum is only 2 doses can be given. After 2 doses, AS should be stopped. No role for a very large dose in neurotoxic phase. In this case, we can go for blood products can be transferred.
One comment. I think even if you don't know the weight, you can give the adult dose for any child. It's not age-based recommendation.
Yeah. It's minimum 10 ml.
10 vials is
Yes.
minimum. Yeah. Okay.
ASV, most common complications, anaphylactic reaction can be managed by, so before starting ASV, the adrenaline, oxygen, IV, and should be made ready. Adrenaline is given the dose of 0.01 ml per kg, 1:1000 dilution is given in IM, and you have to give oxygen, IV fluids, and hydrocortisone can also be given 3 mg per kg body weight, and antihistamines, antigen can be given. In case of circulatory collapse, you have to start inotropes along with IV adrenaline infusion. In neurotoxic snake bite, there is a role of anticholinesterase.
Just one comment. Ranitidine is a very weak agent for any anaphylaxis. You should give only chlorpheniramine maleate or diphenhydramine. In a crate, mostly the anticholinesterase have no effect as they act in the presynaptic nerve terminals. In a cobra bit, they are in the postsynaptic, so it can use of anticholinesterase is there. It reverses the neuromuscular blockade. The dose given is a neostigmine 0.04 mg IM off hourly plus 0.05 mg atropine off hourly for 5 doses to neurological recovery. If no improvement after 3 doses, it is to be stopped. Supportive management, we can give analgesic for pain relief, preferably paracetamol, and antibiotics for infection to cover the anaerobes, and antitetanus prophylaxis should be given. And you should avoid heparin and a replacement of coagulation factors if there is active significant bleeding after giving AS. Next, we go discussion about the B and VAS. Sir, Professor, is there any comments on the snake bite from your experience?
Yeah, I think he has mentioned almost everything. Yeah. The only thing is we have to take the, when it occurred and where it occurred, and that will give an important clue to immediately decide.
Next, we will discuss about the B and VAS stent. The B and VAS stents, mostly they causes anaphylactic reactions due to the release of mast cell mediators and histamine, bradykinin, and it leads to many anaphylactic reactions or urticaria. First, we have to look for the local site examination. Any presence of any strictures is causes swelling and erythema. No further investigation needed and only follow up for that complication. If there is systemic symptoms, we have to check for the ABCD, airway patency, or a breathing difficulties and a bronchospasm, and look for heart rate, blood pressure, and there is an urticaria, flushing, And multi-organ look for the sensorium. Investigations, we look for the renal function test and liver function, coagulation parameters, and urine analysis and hemoglobin peripheral sphere under a T count. Management. First, we have to ask the history, and the repeated action should be remove the stinges, and we should be careful not to squeeze the sac to prevent release of more venom. And then we have to assess the ABCD. If there is only local reactions, we will apply cold compress, and analgesic is prepared, and oral antihistamines like CPM or diphenhydramine, the local reaction persists or stress. And oral steroids can be given for 2 to 3 days in extensive lesion. It's been proper for severe reactions. In systemic reactions, administer injection adrenaline, and the dose of 0.01 ml per kg given IM, and the high flow oxygen is started, and we have to assess the airway. If there is a partial obstruction, we have to repeat adrenaline every 5 minutes. If needed, adrenaline infusion should be started, and the patient should go to the PICU. If there is a complete obstruction, we have to start mechanical ventilation, and adrenaline is given every 5 minutes. An injection hydrocortisone is given. And look for a breathing. If there is apnea or wheeze due to the bronchospasm, we can give a nebulization salbutamol and repeat adrenaline every 5 minutes. And if required, adrenaline infusion should be given. Let's assess circulation. There is no pulse, and the basic advanced life support is given. And we can shorten inotropes, and we can again ventilation shift to PIC.
Very important topic.
And nowadays it's happening so commonly.
So we will discuss about the human bite. The human bite is most 1% of patients present in the year is the most common. It's most common bite after dog and cat bite. Because human saliva is polymicrobial, contains 50 bacteria and 10 power 8 microbes per ml. There will be 2 types of bite: occlusion bite or closed fist bite. The closed fist bite is dangerous as it involves the 3rd, 4th, 5th, and metacarpal and metacarpal phalangeal joint. As they are avascular areas, they lead to more infections, and necrosis can occur. In children, there is low infection rates due to the less disease teeth in children, and gingivitis is less common in children. But in if adult bites the children, the infection will be severe due to more number of disease teeth and gingivitis. The most common organisms in human bite are Streptococcus, Staphylococcus, Legionella, Prevotella, and Fusobacterium, both aerobes and anaerobes. And Streptococcus antiosus, most common organism isolated in the human bite. And radiograph must be obtained in case of clenched fist injuries, scalp wounds, to rule out any fractures, presence of foreign bodies, teeth fragments, and in rare cases, osteomyelitis can occur. And management, first should be irrigation with a normal saline or povidone iodine. And if it is a non-infected wound, first parenteral dose is given IV ampicillin sulbactam 50 mg per kg single dose, followed by oral amoxiclav 45 mg per kg in 2 divided dose for 3 to 5 days.
Ampicillin sulbactam is not widely available, only amoxiclav. Okay. It's not widely available. Even oral ampicillin is not easy to get, and more so is parenteral. Amoxiclav is very much equally effective. Except maybe a few crab is one organism which will respond very well to ampicillin sulbactam. Otherwise, there's nothing specific about ampicillin sulbactam over amoxiclav. Because Western textbooks would mention always ampicillin sulbactam, which is not available in India.
In fact, we give IV amoxiclav for 3 days and followed by oral amoxiclav given for 3 to 5 days. Thank you.
Sir, Professor Srinivasan, sir, any comment? You can stop sharing this.
No comments. Yeah, actually, there's a lot of noise there, though I have muted. Yeah, there is nothing much. He has already covered most of it.
Okay. So, from any other comments from learned faculty, including Professor Bagdi, sir, any comments from you? Okay. Snehal
Very
is
good, sir. Very nicely presented. I must congratulate.
very well.
I think a lot of whoever has listened has learned quite a lot today. Very good, sir.
Dr. Nivedita, you have anything to add, Dr. Nivedita? Madam?
No, sir. Thank you, sir.
No,
Okay.
very well presented, team. Nivedita, Dr. Nivedita and your team. Very well done.
Okay. Snehal, do you have time for 10 minutes? As I promised, I had put some aims. Frequently
Yes,
asked questions in rickets. Last class, you remember I
Yes,
promised.
yes, sir. Yes, sir. Yes,
Is there
sir.
time? Can I share the screen?
Yes, yes, sir.
Yeah. Allow me to share the screen. 1 minute only. Just a minute.
So you are host. You can share screen.
Okay, 1 minute.
You are going to show ASCIIs?
No, ask it. Frequently allow. Okay. Frequently asked questions in thing. I just. Yeah. Is my screen visible? Hello?
No, sir. No.
1 minute. I don't know what's the problem. I don't know where is the problem. It's taking me somewhere else. I don't know. There is some problem. There's some problem because mine is Apple. That's a problem. Last time also, remember there is a problem. Allow Zoom to open. I don't know. I'm not able to share the screen. No.
So it is PowerPoint.
It is PowerPoint only.
So if you can WhatsApp me.
Yeah, 1 minute. I'll do that. 1 minute. PowerPoint, WhatsApp. I'll do that. 1 minute. Just a minute. I'll WhatsApp.
Dr. Satish, can you do that?
Yeah, I'll just WhatsApp you. 1 minute. Yeah. Exactly 30 seconds will be. Yeah. Now. Yeah, I have done it. Yeah, I have done it.
Yes, sir. Let me try.
You got it?
So I'm trying 1 minute.
Just reached you, no?
Dr. Satish. Dr. Satish, are you there?
No, I don't think it's there. Okay, just it's okay. We'll have it next time, no problem. Because
Hello, sir.
yeah, you
Dr.
shall I
Satish,
what?
co-host is not able to share. Even I am not able to share. Sir is co-host. If you can make sir host, no, he will be able to share.
Okay. Just a minute. Huh?
Yeah, just a minute.
You can see, sir, right now.
Yeah. No, No, it is taking me to a different thing, Dropbox, OneDrive, Google Drive, like that. Not taking me to my screen.
It is showing here also. I am not able to.
That's some technical problem.
Yes, sir. Yes, sir.
Okay, leave it, Snehal. Next class, I'll start with that and then proceed.
Okay, sir. Okay, sir.
Because last time I promised I put some frequently asked questions on rickets.
Dr. Satish, if I send it to you, can you display?
Actually, I am joined with the mobile. That's why the problem is there.
I think, sir, next time you prior send it,
Yeah.
and then we
Yeah.
can see if we
Yeah,
can
no
display.
problem.
Yes,
No
yes,
problem.
we'll make it that.
No problem. Any comments from Snehal?
No, sir. Nice presentation. You only comment now. Very well done and elaborate presentation with cases. That was good.
Very good presentation. In fact, I learned a lot because this is not my area of expertise. Of course, Dr. Srinivasan has rich experience. Sir, your final comment before we close the show.
No. Yeah, it was very well presented. Yeah. And of course, very informative. Of course, I thought of asking Satish Sane's permission to invite he had given this oration in Maharashtra Pedicon, Dr. Mahadevan. So we had invited Dr. Bavaskar to come to Jipmer, and he stayed for 2 days and then extensively brightened our knowledge about that. And then, of course, from that time
he's done
onwards,
lot of
Mahadev
good.
was very much interested. Yeah.
Our area is known for red scorpions, sir. Spoken.
Yeah.
Okay.
Sir, does it come in OSCEs or practical?
Yeah, OSCE is very frequently asked. Dog bite as well as snake bite, scorpion sting. In fact, I still remember Dr. Mahadevan's picture of a child with priapism with a history, but there is there in the OSCE bank.
That is his favorite, this thing.
Yeah. Similarly,
And Tangavelu also has put this thing.
Yeah. It's a very frequently asked OSCE question. Toxidromes are important. Okay.
Okay, thank you, sir.
Okay, thank you, ma. Thank you. Good night.
Thank you.
Good night, sir. Thank you.
Good night. Yeah.